delighted to welcome Dr. Abhilash Koratala, Associate Professor of Medicine and Director of Clinical Imaging for Nephrology at Medical College of Wisconsin, USA, who will share his expertise on POCUS for fluid management in the ICU through an engaging case-based discussion, helping us address the clinical and critical question when to diurese and when to dilate in the fluid overloaded AKI patients. Now, Dr. Abhilash Koratala is our one of the, I would say, most important and also a very highly noted speaker from the NephroCritical Care Society, and he has made exemplary contributions in advancing POCUS applications in nephrology and critical care, shaping practice and education worldwide. As a valued faculty who closely associated with our society, he continues to enrich our mission of compassionate nephrology and critical care. Welcome, Dr. Abhilash Koratala. As always, you are one of our highly noted speaker.
Thank you so much. Thanks for the kind introduction, and it's always a pleasure to be here. Good morning, everyone. So in this brief talk, my intent is not to teach the entire point of care ultrasonography in the ICU or even point of care ultrasonography that covers the entire breadth of volume management. I think when trying to learn POCUS, it's important that we have a good understanding of why we are doing it and what are the questions we should ask POCUS and where it can help us, and what are the questions which we shouldn't be asking POCUS or not performing POCUS for. So I'll provide a brief overview of how we utilize point of care ultrasound in the ICU and beyond for volume management. I have no active disclosures. First of all, what is POCUS? I know some of the audience may already know what POCUS is, may already be using POCUS to some extent, and some are novice users. So I'll start with the definition. So it's the ultrasound examination performed at the patient's bedside, that is at the point of care, by the clinician himself or herself, not the radiologist, to answer focused clinical questions. And what are these focused clinical questions? These are some questions that we have in mind after careful history taking and physical examination. And answering this will either provide the diagnosis or at least narrow the differential diagnosis. POCUS is also used to guide bedside procedures such as placing a dialysis catheter or performing a kidney biopsy, paracentesis, thoracentesis, and so on. And in a lot of places, you typically don't do blind procedures without POCUS anymore, at least in the United States. And what are some examples of these focused clinical questions? Does this patient with acute kidney injury have hydronephrosis? And instead of you waiting to get result from the formal or radiology performed ultrasound examination, if you are at the bedside, you take history, you just pick up the probe and look at the kidneys. It takes 2 minutes to answer that question. And does this patient with shortness of breath have pulmonary congestion? Or maybe the lungs are clear and you have to think about other causes of shortness of breath. So you get your answer in a minute. And you're dialyzing a patient who is becoming hypotensive during ultrafiltration, and you have a suspicion for pericardial effusion, and you don't have to wait for a comprehensive echocardiogram to be done, and you get your answer then and there, and you can do whatever needs to be done, either reduce the rate of ultrafiltration or send the patient to the emergency room, or if you're an intensivist yourself, you do a pericardiocentesis. And over the past several years, point of care ultrasound has evolved as a component of physical examination. In addition to the traditional 4 pillars of inspection, palpation, percussion, and auscultation, insonation or using POCUS is now considered the 5th pillar or an essential element of bedside examination. And why do we call it a component of physical examination? Because first of all, what is physical examination? It's the process of evaluating objective anatomic findings at the bedside, and you get some information and you thoughtfully integrate that information into patient's history and clinical context. And that's what exactly point of care ultrasound is letting you do. I mean, physical examination you can do with hands, or let me see, just a moment. You can do with your hands, or you can use a tool. And these are all the tools we are familiar with: reflex hammer, flashlight, stethoscope, tuning fork, your measuring tape, and sonoscope has joined our toolkit as a new bedside diagnostic tool or bedside diagnostic aid. So that's why at least in principle, point of care ultrasound is an extension or a component of physical examination. So coming to AKI, what are some focused clinical questions we have in AKI after we rule out obstruction? Should I give this patient fluid? That means, is this patient volume depleted? Or is this patient volume overloaded? Then I should remove fluid either by diuresis or ultrafiltration. And maybe the patient's heart is not working well, so maybe the patient needs inotropes. So all this information you gather by doing point of care ultrasound in just a few minutes while you're at the bedside. And once you answer that initial question, then you have further questions. Did I give adequate amount of fluid? Did I remove adequate amount of fluid? So it's a continuum of asking questions at the bedside, which normally without POCUS, like we either rely on comprehensive imaging or we just use our empiric judgment. We look at intake output data, weight, but all these are error prone. But POCUS provides you more objective data. Also, you can't like order a echocardiogram every day, and that's not practically feasible nor economical to do it. And I assume like most of you know the blind man and elephant story. It's a old story from British India where these there are these blind people who never saw an elephant, obviously, and the elephant comes to their village, and these guys start to feel a particular part of the elephant and try to describe how elephant looks like. So this guy here says elephant looks like a spear because he feels this tusk. This guy says elephant is like a snake because he feels the trunk. This guy says elephant is like a pillar. This guy says elephant is like a fan because he feels the ear. And this guy says elephant is like a wall because he feels this part. And this guy says elephant is like a rope. So how does this apply in the concept of AKI? And as clinicians, we are essentially blindfolded if we don't have objective data at the bedside. And like all roads lead to Rome. Most of the time, like all the questions we ask ourselves are biased and lead to administering intravenous fluids when we objectively when we interpret the data without much objectivity. So this guy says like documented negative fluid balance is negative, so we should give fluids to this patient with AKI. Urine sodium is less than 20, so we should give fluids. The patient is hypotensive, give fluids. The lactate level is elevated, give fluids. I auscultated the lungs and lungs sound clear to me, so give fluids. And this guy says the patient has AKI and every AKI needs fluid. So we become blindfolded without objective data, and POCUS helps to gather objective data. And we rely so much on daily weights and documentation of the intake and output, and obviously we all know it's highly error prone, and it's as accurate as a patient scale that you are using. Some days you use the actual weighing scale, some days you use the scale attached to the bed, and sometimes the nurse throws away the urine without documenting and so on. Uh, so look, how do we assess hemodynamics at the bedside? More precisely, rather than saying volume status, we should say hemodynamic assessment, right? Again, none of these tools or diagnostic aids or even laboratory tests, none of them directly measures volume. Actually, we do have a commercially available test to measure volume, which uses radio-tagged albumin, but that's not like universally available. Even in the US, it's not available in most places. Um, so essentially, we don't have any test that measures volume itself. So with POCUS or even with invasive things like pulmonary artery catheter, we 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 um, we assess hemodynamics, not necessarily volume status. And what does it mean? So it's a three-part evaluation, right? So first, we want to know how is the forward flow? Is the stroke volume enough? Is the cardiac output enough that way the blood is reaching the organs? And are there any effects of elevated back pressure? So if the left heart pressures are elevated, so that's going to go into the lung. So you have increased extravascular lung water or pulmonary edema. And if the right-sided pressures are elevated, then the back pressure is transmitted backwards into the hemodynamic circuit. So you develop congestive organ injury like congestive hepatopathy or congestive nephropathy. So it's very essential that when evaluating a patient with AKI, especially when you're contemplating intravenous fluid therapy, we have answers to all these questions. So how is the forward flow? Is there pulmonary congestion? Is there any evidence for organ congestion? So how good is our physical examination for that? So normally to assess cardiac output, what tool we have at the bedside? We just like feel the temperature and try to differentiate patients into warm and cold. And there is a meta-analysis that looked at several studies which evaluated this parameter. And 5 studies showed no correlation between the temperature that you feel and cardiac output. And 3 studies showed only moderate correlation. And only 2 studies out of 8 showed that cool temperature is associated with lower cardiac output. So practically, it's almost a useless thing. And how about for elevated back pressures? This 1989 study in a large cohort of heart failure patients. I mean, it's not a large cohort necessarily, but it's a sizable cohort of heart failure patients with elevated pulmonary capillary wedge pressure of more than or equal to 22 millimeters mercury. What they found was the combined sensitivity of Rales edema and elevated JVP was only 58%. It's pretty much close to flipping a coin. And this is another large meta-analysis of 22 studies. And among these heart failure patients, only 2 physical examination parameters with a good positive likelihood ratio were S3 gallop and abdominojugular reflex, and their sensitivity is horrible. So it's essentially nothing, and you rarely hear S3 gallop or I mean abdominojugular reflex. These things are like rarely felt or appreciated, especially in the busy ICU settings. Auscultation is very difficult when you have a lot of noises around. And do we properly do physical exam? We stress so much on physical examination. I examine the patient every day. But I think we tend to just assume that we do well, but we actually don't do. In a Twitter poll, I was asking people like, how many of you actually do JVP assessment this way, like using 2 instruments? You want to measure the height of the collapse point or the height of the highest point of venous pulsations from the jugular notch. And more than 60% of the people said they never do it this way, and 14% said rarely. Only less than 20% of the people said almost every day. And I never do this anyways. So how does POCUS help in this regard? We said we need good hemodynamic assessment. We said physical examination is not so good. So is POCUS any good? So if you add point of care ultrasound to auscultation, like if you compare it to auscultation, the sensitivity to detect left ventricular dysfunction goes from 43 to 84%. And the sensitivity to detect valvular heart disease goes from 46 to 94%, which is considerable increase. And but the specificity is not hugely different. Of course, it does go up, but it's not hugely different. What it means is the conventional examination parameters were, or the classic signs and symptoms were described when late presentations of diseases were common. So if you find a positive finding, that's valuable. But if you do not find, it does not mean anything. Um, and similarly, in dialysis patients, what they found was the sensitivity of lung crackles and peripheral edema was only 9 and 3% respectively when they compared it against ultrasound detected pulmonary congestion, though their specificities were fine. So again, if you don't hear crepitations, it doesn't mean anything. If the patient doesn't have peripheral edema, it does not mean they are not fluid overloaded. So it also tells you that you definitely need more objective tools than your conventional physical examination. And in a cohort of ARDS patients, ultrasound consistently outperformed not just physical examination, but also chest radiography in detecting pleural effusion, consolidation, and interstitial syndrome. So even chest X-ray might not be that sensitive. That has also been showed in pulmonary edema patient, cardiogenic pulmonary edema patients. So in this meta-analysis of 8 studies, lung ultrasound had higher sensitivity and specificity compared to chest X-rays for detecting cardiogenic pulmonary edema. So essentially, there is really no role for getting repeat chest X-rays in the ICU or on the wards. If you want to see if the patient's pulmonary congestion is improving or not, all you need is a probe. And does POCUS change management? In this large cohort of over 1,000 patients with shock, using POCUS has changed management in 54% of the cases. That's really a huge difference in patient management. And echocardiography was performed within 72 hours in 54% of these cases. So if you perform early, before you saw the patient, before you did some empiric management, the likelihood that you change management would even be higher than this. And while some nephrologists and critical care physicians are debating whether to incorporate POCUS or not, or whether POCUS falls in their scope or not, now it's even spreading to patients. Like they have tried giving these handheld ultrasound probes to patients with heart failure, and they do their own lung ultrasound at home, and they send the images to physicians. That way, they can see if they have pulmonary congestion or not, if it's worsening or not. So there is no discussion here. Like POCUS is already here. It's a part of physical examination. It's here to stay. If we don't learn, it's just that we are not only lagging behind, but it's sort of injustice to the patients that we are treating. And also, when you're learning POCUS or actually doing POCUS, never perform phantom scans. Phantom scan means like you do a scan, but you don't save the images. Like if you don't save the images, that means I mean, it's essentially equivalent to you have never done it. Saving the images will help you bill for the scans and receive feedback when you have questions. And if you're rotating with trainees, it helps you to give feedback to trainees, because you're not always at the bedside. You're not rounding together always, and they can save the images and show it to you. Or if you have doubts, you ask your expert colleagues. So never perform phantom scans, whether you are a POCUS learner or a POCUS practitioner. So I think that tells you the necessity of POCUS. In the next part of the presentation, I'll briefly talk about some common scenarios we see in the wards or in the ICU in the context of AKI and fluid disorders. So you have a patient with acute kidney injury. Your question is, should I give fluids? What are we looking at? So this is towards head, this is towards feet. Here we have a big blood vessel that goes into this beating structure, which is heart. So more precisely, this is the right atrium, and this is the IVC. And IVC is nothing but a tube that's connected to the right atrium. So if the right atrial pressure is high, IVC is big and less collapsible during inspiration in a spontaneously breathing patient. And if the right atrial pressure is not high, the IVC is small and more collapsible, or typically more than 50% decrease in diameter during inspiration in a spontaneously breathing patient. But here, if you look at this IVC here, this is pretty big, and here is a scale. So it's more than 2.1 centimeters, and it's barely moving with respiration. So you can say that the right atrial pressure is high. So if the right atrial pressure is high, you're not going to give fluids, because the risk of fluid administration exceeds benefit in this case. This just shows you again the inferior vena cava illustration. It's just a flipped image. In this image, we are seeing the head here, feet here. In this image, we are seeing the head here. Just usually head is towards this marker. And we measure the IVC diameter and collapsibility approximately 1 to 2 centimeter below the hepatic vein IVC junction. So here is the hepatic vein. Here is where you are measuring. In this case, the IVC is normal. It's collapsible by more than 50%. So the answer is that this patient wouldn't benefit from intravenous fluid administration. Either the patient has congestive nephropathy, or even if the patient doesn't have congestive nephropathy, maybe the AKI is because of something else. But it's unlikely that if you give fluids and increase cardiac output, the likelihood of benefit is low. Unless the heart is not working at all, that's a different story. That's why you have to look at the heart too. You can't just leave at IVC. And here is another patient with AKI. Should I give fluids? What are we looking at here? We are looking at these areas. So we are sono-auscultating the lung, or performing a lung ultrasound. And these are the images that we get. So what do they mean? For those of you who did not perform lung ultrasound before, so lung ultrasound is easy. Lung is filled with air. air is enemy of ultrasound. It scatters the ultrasound beam. So all you see are artifacts. If you see horizontal artifacts like this, these are called A lines. That means lung is filled with air. That is a good thing. If you have these vertical lines, that means they are called B lines. And if you see B lines, that's bad. In other words, it suggests interstitial edema, which is most likely because of cardiogenic pulmonary edema in our case, or fluid overload. But you can also have interstitial thickening because of lung fibrosis, and you can see B lines. But say you don't have any of those confounders in our patient with AKI. And here what we are looking at is this bright line is a pleural line. Here is pleural line. Here we are seeing all these vertical artifacts. So vertical artifacts moving with respiration. So these are all B lines. So the patient has pulmonary edema. So giving more fluids is harmful in this context. So a lot of people think I do IVC and lung ultrasound, so I am an expert in volume status assessment. First of all, I already told you that this is not volume status assessment. Ultrasound doesn't evaluate volume status. It evaluates hemodynamics at the bedside. Um, but apart from that, is only IVC and lung enough? So what does IVC tell you? It tells you about the right atrial pressure or central venous pressure, right? So what determines central venous pressure? Uh, here you have the heart and the blood vessel or the venous system, which is a compliant system like a balloon, right? So they can expand if you add more fluid. So what determines right atrial pressure? One thing is volume, obviously. So if you have more fluid in the system, your central venous pressure will be elevated. And it also depends on the right heart situation. So if the right heart is not squeezing well because there is maybe RV infarction or chronic RV dysfunction, typically in the setting of chronic pulmonary hypertension or acute pulmonary embolism, and so on, basically lung disease, ARDS or whatever. So if you have right heart dysfunction and lung dysfunction, then your central venous pressure is elevated. And if you have tricuspid regurgitation, central venous pressure is elevated. It also depends upon the compliance of the right atrium, how much fluid the right atrium can accommodate. And it depends on the compliance of the venous system too, how much fluid it can accommodate. Because IVC is a compliant tube. So if the central venous pressure is elevated, before it goes to the kidneys, the IVC must dilate first. And unless you do Doppler assessment of the blood flow here, it's hard to know if that elevated central venous pressure is affecting the perfusion or not. And it also dependent on left heart situation. If you have left heart failure, then obviously the pressures are going back into the right heart and leading to elevated central venous pressure. You can have a mitral regurgitation leading to elevated central venous pressure. Basically, that's within the heart, and from outside of the heart, say if you have increased pericardial pressures as in pericardial effusion, that raises the central venous pressure. Or if you have increased intrathoracic pressure as in pneumothorax or large hemothorax, large pleural effusion, or even morbid obesity, you have BMI of 60, then that's going to increase the intrathoracic pressure. That's going to affect the CVP too. And also when assessing IVC ultrasound, you have to pay attention to intra-abdominal pressure because it's an abdominal vessel, and it's not only the volume or the pressure within the system, but if you have more pressure extrinsically, your vessel will look smaller than it should be. So it might not be reflecting the central venous pressure. So we have to take all these factors into consideration when interpreting the IVC, and IVC should not be equated to volume. And basically, the teaching point is that the right atrial pressure only measures the volume state when the heart is stopped. So if the heart is beating, there are so many dynamic components that determine right atrial pressure and thereby influence inferior vena cava. So if you are saying, I looked at the IVC, I assessed volume state, that's technically a wrong impression that we are giving. And sometimes IVC is just like influenced by local factors. For example, this is a guy with this is a patient with liver disease. You can see like the liver is so bright, and I measured the IVC here. It's 2.88 centimeters. Normally, more than 2.1 is considered to be uh, uh, dilated IVC. So I would assume the right atrial pressure is high. But then I looked at the internal jugular vein. It was pretty collapsed at the neck base. And when you look at the internal jugular vein ultrasound, uh, basically it's where it is collapsing or where you are seeing the highest point of venous pulsations, right, in the neck. So this guy's IVC was collapsed here. That means the right atrial pressure is unlikely to be high. And also you can do the Doppler assessment. And Doppler assessment of internal jugular vein is like CVP waveform, right? Like you have the A wave, you have the X descent, V wave, and Y descent, or in these terms we call like systolic wave and diastolic wave. And these are normal configuration. So your CVP waves are essentially normal. IJ seems to be collapsed at the neck base. If I'm just reliant on IVC, my decision would be flawed. So you need to know what are the problems with IVC assessment, and in which patients it might not be reliable, especially in cirrhosis. I know there are like a couple of studies that said IVC ultrasound is great in cirrhosis, but no, I mean, if you really do it in cirrhotic patients, you would know how applicable that is. Okay, fine. So coming to next point. So you didn't give fluids for a patient, say previous patient with B lines. And is there anything else to check on POCUS? You just say, I looked at B lines and give diuretic and walk away, or is there something else? So obviously there are B lines. You have pleural line here. You have multiple vertical artifacts. So there is pulmonary congestion. Then you should always look at the heart. So look at this heart here. Even if you don't, I mean, do cardiac POCUS, like you can easily appreciate that you have 4 chambers here. RV, RA somewhere here, left atrium, left ventricle. And look at this mitral valve here in the middle, which looks very funny and prolapsing, and here little bit of thickening. You put color, and there is a huge amount of regurgitation coming back into the left atrium. So what do we have here? Like you have pulmonary veins here, right? So if there is so much regurgitation coming back to the left atrium, and that's going to go back to the pulmonary veins, and obviously it's going to go to the lungs. So you have pulmonary congestion. So if you miss this thing and the patient had a vegetation here, and the patient keeps coming back, your one dose of diuretic is not going to really help the patient. So it's very important that you look at the heart. And in the same scenario, maybe if you look at the heart, maybe you'll find this. This is the long axis view of the heart. This is the right ventricle. This thing is the left ventricle. And here is the left atrium mitral valve. So this, just by looking at this, you can appreciate that the LV is not at all squeezing. So this patient has severe heart failure, and that's why he has pulmonary edema. So this patient needs a proper assessment, comprehensive echocardiogram, ischemic workup, whatever is applicable in the clinical setting. And remember that B lines are not specific for cardiogenic pulmonary edema. As I said, B lines just indicate interstitial thickening, which can be because of cardiogenic pulmonary edema or acute respiratory distress syndrome, pneumonia, even diffuse alveolar hemorrhage. That's important to note because you can have pulmonary renal syndromes, and you can't just see B lines and say give diuretic and move on. You have to you have to interpret that in the context of other findings, maybe pre-existing interstitial lung disease. And physiologic B lines, usually like not a lot of B lines, but you can see a few B lines in the dependent zone sometimes, especially in elderly patients. So interpretation in the clinical context is really important. Okay, here is another case. You didn't give fluids to a patient with plethoric IVC, which is a good thing, but is there anything else to check on POCUS? So here is IVC that's not at all collapsing with inspiration, and it's pretty dilated. If you closely observe, the moving structure is here, but there seems to be some gap here. And we'll obviously look at the heart. So we look at the heart. So here I gave you a picture also. So here is a long axis view of the heart, and surrounding the heart, there is a black thing here. So that means there is a lot of pericardial effusion. Not a lot of pericardial effusion. There is pericardial effusion. However, like if you look at this right ventricular outflow tract, it seems to be collapsing. And if that collapses during diastole, that's suggestive of tamponade, right? If you do, normally cardiology echoes have EKG, so you know you can stop and see where it is collapsing. But if you don't have EKG, you can just look at the valve. So you freeze the image, the mitral valve is open here, the RV outflow is collapsing there, so that there is diastolic collapse. This is suggestive of tamponade. So what happens, say assume this is an AKI patient or ESRD patient that you're taking for dialysis, and because the IVC is plethoric and you don't know how to look at the heart, or you didn't suspect pericardial effusion, you just wrote for an ultrafiltration of 4 liters. And what happens during dialysis? During dialysis, you are removing the fluid from within the heart. That means the pericardial pressure will become higher relate to the intracardiac pressure, and the patient will develop tamponade physiology, and the patient will become hypotensive. Then you give fluids, then you don't realize there is pericardial effusion. It keeps going on. So it's very important that any hypotensive patient, regardless, deserves a point of care ultrasound exam. And always remember that hemodynamics are dynamic, and a recent echocardiogram does not eliminate the need for POCUS. I hear this all the time. The patient had an echo 2 days ago. Do you want to do POCUS? Yes, I want to do POCUS if I have suspicion for an ongoing hemodynamic disorder. It doesn't matter when the patient had an echocardiogram. And one last scenario. I think we are doing okay on time. Here we have a patient with hyponatremia. And the physical examination shows this. And by physical examination, I mean POCUS, obviously. Here is a nice inferior vena cava. It's small and completely collapsible. Now, a nephrologist comes and says the IVC is small and collapsible. This is hypovolemic hyponatremia, and we should give fluids. Do you agree? It may be or may not be, because we said that if the IVC is big, then the right atrial pressure is high. But if the IVC is small and collapsible, it just tells you that the right atrial pressure is not high. It doesn't discriminate between hypovolemia and euvolemia. So in this case, if the patient is hypovolemic, your fluids would help. And if this patient is euvolemic, your fluids might still help if your urine osmolarity is low, right? Like if your urine osmolarity is lesser than that of normal saline, say 150 or whatever, then it would still help. You falsely assume the patient is hypovolemic. But if the urine osmolarity is 450, then if you give normal saline, your serum sodium will drop in this case if the patient is euvolemic, right? That you all know as nephrologists. But then what do you look at? You look at the stroke volume. You look at how the blood is flowing out of the heart. So this is the left ventricular outflow tract Doppler here. So with each heartbeat, your blood is going out. And if I trace that, I get a number called VTI, or velocity time integral. So this is the time and this is the velocity. So if you do the integral of that, you get a number in centimeter. Normal velocity time integral is say 17 to 23 centimeters, and you can use that as a surrogate for stroke volume. In this case, it is 28, which is obviously higher than normal. So this patient is not volume depleted. If your stroke volume is normal, you're not volume depleted. So it's a euvolemic hyponatremia. And the same applies in cirrhotic patients too. We tend to assume that they're volume depleted because they're on lactulose or whatever, or they're not eating well. And if you do the cardiac output estimation, a lot of times you have like cardiac output of 10 liters, 12 liters. I mean, because they have high cardiac output state at baseline, a lot of them. And what's the point of giving fluids, whether crystalloids or colloids, to a person with a cardiac output of 10 liters? Because the ultimate goal of giving fluids is to increase cardiac output in an attempt to enhance perfusion. So there is no point in doing that without proper assessment. So the teaching point is a small collapsible IVC does not distinguish between hypovolemia, euvolemia, and a high cardiac output state. I'll also say that the IVC ultrasound does not predict fluid responsiveness. IVC only tells you about the right atrial pressure. If you look at the Frank-Starling curve, if the patient is operating here on the steep portion, the right atrial pressure is high, or the central venous pressure is high, and the IVC is expected to be big. So the patient is unlikely to respond to fluids. If the patient is operating here, the central venous pressure is low, IVC is expected to be small, the patient will respond to fluid. But if the patient is operating in somewhere here, you don't know whether the patient would respond to fluid or not. So intermediate ranges, IVC is not helpful. IVC is helpful only in extremes. And also not everybody's Frank-Starling curve is the same. So a lot of patients have a right shifted Frank-Starling curve. So if you give 1000 cc of fluid to this patient here, he might do okay. But if you give 500 cc to this patient, that patient might go to fluid overloaded state. So it essentially remains an educated guess, and IVC should not be used to predict fluid responsiveness. I specifically mentioned this because when you look at IVC literature is so much, will take you down this rabbit hole of fluid responsiveness. And the real question is, how does fluid responsiveness help? Whether you use IVC or you properly do fluid responsiveness check using stroke volume, pre and post bolus or pre and post leg raise, you do somehow, and you get a answer to this question. This patient is fluid responsive versus not. So what to do next? Should you fill the tank? No, you shouldn't, because fluid responsiveness is a physiologic state. All of us must be responsive to fluids. All of us must be able to mount additional stroke volume if we get fluids. If our heart is working well. So it's a physiologic state. So exhausting fluid responsiveness is never the goal of therapy. So this is a teaching point. It's a physiologic state, and don't try to exhaust it. So it's a question of limited use at the bedside, and patients who are fluid responsive can still have signs of congestion, according to a recent study, and the giving fluids would probably harm than do good. I'll stop here in the interest of time. Basically, you just don't stop at IVC. You look at the venous flow in the hepatic vein, portal vein, and renal veins to see how the blood flow is altered, to know if there is congestive organ injury. And these waveforms are dynamic and change with fluid removal. So that would be really helpful. So again, hemodynamics, you need to look at forward flow and effects of elevated cardiac back pressures. And a probe in your pocket doesn't make you a POCUS pro, and you should still use your judgment, skill, and ability to recognize its limitations make you a POCUS pro. I hope this lecture, again, like my intent is not to teach POCUS, but to give you an overview of how to do it and what are the limitations. Thank you so much for your patience. If we have time, we can take questions, but
Hello, sir. Thank you so much
yeah.
for the wonderful lecture. I would just like to ask you, how do you use VEXUS in your daily practice? Since it's an extension of, fluid overload state, and how do you use that?
Yeah, I mean, unfortunately, I couldn't cover the topic of VEXUS because it's a vast topic and it's a whole lecture by itself. But VEXUS is extension of inferior vena cava examination. Like I said in the last point, IVC tells you that the right atrial pressure is elevated, but it does not precisely tell you if that congestion is reaching the end organs versus not, whether there is congestive nephropathy or not. VEXUS tells you that the circulation or venous flow has altered at the organ level, and therefore the likelihood of congestive organ injury is high. And these waveforms are dynamic and they change with treatment, so you can follow them at the bedside even when your physical signs like pedal edema are not reliable. So yeah, if the question is like if I do VEXUS every day, yeah, I do VEXUS every day. If I'm doing POCUS, I most likely do VEXUS also, to gauge response to treatment. Yeah. I mean, it's a very broad question, so it's a whole lecture. I can dedicate 1 more hour if you have 1 more hour someday, but I think for now,
Yes.
yeah.
Exactly, Dr. Koratala. This is a completely separate topic, and it would take almost 1 hour for Dr. Koratala to at least give some idea and insights about VEXUS. So thank you, Dr. Koratala. I know you are so busy, but on behalf of NephroCritical Care Society and all the 45 trainees now in this hall, and there are many also online. So we extend our heartfelt gratitude, and we also wish that we continue to collaborate further. And thank you very much for your invaluable contribution since day one of our society activities and different review courses and continued support. Thanking you very
Thank you
much.
so much.